Okay, welcome everyone to this webinar again. This is the second in our series in the COVID era, and we are today at Girdhar Eye Institute, Cochin, which is NABH accredited hospital, which was established on 8 September 1997, and it is a we have with us today Dr. S J Saikumar, who will be operating, who's a medical superintendent and head of cataract and glaucoma services, and Dr. Girdhar A, medical director and chief mentor, who's going to be doing retinal detachment surgery. We also have Dr. Mahesh D with us, senior consultant and head of the Department of Vitreoretina Services, who's also the chairperson for the Kerala State Secretary of the Kerala State Ophthalmic Society, and Dr. Vinay Sukumar Pillai, Senior Consultant and Head Cornea and Refractive Surgery, Dr. Marian Collins, Senior Consultant and Head Oculoplasty, Orbit, Oculo-Oncology and Oculoprosthesis. And there will be a demonstration of 3 cataracts, 2 intumescent cataract and 1 nuclear cataract. And apart from this, they are also going to be demonstrating the retinal detachment surgery. I have with me our president, All India Ophthalmological Society, Dr. Mahipal Sachdev, and treasurer, All India Ophthalmological Society, Dr. Rajesh Sinha. So without much ado, I think we'll begin the surgical session.
Good afternoon, everyone. I'm Dr. Sandhya from Girdhar Eye Institute. Dr. Saikumar is doing the surgery. Our first case is a 53-year-old lady with an intumescent mature cataract in the left eye. She is pseudophakic in the right eye with a multifocal IOL.
Can we have the microscope view, please?
Microscope,
yeah.
Is the magnification correct, madam?
Yeah, everything is good. You can start, I would say.
Yeah. The mature intumescent cataract. The other eye of the lady is pseudophakic in the other eye. She's got a multifocal lens in the other eye. She should have actually done this earlier, but for the pandemic, I think she got delayed a bit. So we are making 2 paracentesis here. And obviously we're using trypan blue to stain the capsule. So these are the sort of capsules where you can get a rexus tear quite easily. I usually do the trypan blue staining under air. There are of course various techniques to do, but I find it comfortable to do under air. And I usually don't wash it again. I just directly put some HPMC. Viscoat. And it's my preferred technique to put some viscoat on top of the capsule there, air. I stabilized the globe. This patient was a bit apprehensive, so actually we have given a peribulbar block in this patient. So in case we need to convert or something, then it becomes easier. Some fluid cortex coming out. Blue paracentesis. Microrhexis forceps. I'm using a microrhexis forceps here to make an initial rhexis. Cornea.
So in case, Dr. Sai, if you want to decrease your zoom, you can. For us, it is quite magnified. So just...
Is this okay, madam?
Yeah, perfectly all right. Beautifully, I think it is getting spiral.
So we have made a small rexis now
So
by
it's
manual.
not centered. It's not centered.
Yes, now it is okay. Perfect.
Vacuum method. आइए.
Okay, so initially you would make a small rexus and then take
Yeah.
out the fluid.
And then, slightly decompress the bag here. And so that I can make a larger rexis and then proceed. But some of these cortexes are actually slightly resistant. You can actually milk out some of the cortex like this before aspirating. Gel. Here again, I use a bit of viscose. I feel it compresses the capsule well, and it holds on there during the extension. And the microrexis scissors is now being used to make a small nick in the capsule. And while making the nick itself, you will know the intra-bag pressure, because when you make the nick, if you see a V-like opening of the nick, that means the capsule pressure is still high. But if it is something like a straight line, then you can obviously know that the pressure is under control.
So I think this is a very nice technique that first you will do a small rexus and then you consciously do a small rexus and then followed by aspirate
And
to the fluid. Any
sometimes
yeah.
Sometimes we have noticed that even this rexis may not be 2.4. Sometimes we notice that even this rexis may appear a bit small once you put in the intraocular lens. And then we do a third rexis to just make sure that the size of the rexis is quite okay. Now, since we have already aspirated some of the cortex and this nucleus itself is not very hard, there's no need for a hydrodissection here. The nucleus rotates very well. Grade 2.
So I also noticed that you made your main incision after you've done your rexus.
Exactly. So in case I'm having some issues with the rexis, if I by some chance need to convert into an SICS, then I'm not committed on my main incision.
I think, Dr. Amrita, the other issue advantage is that you want the chamber to be as watertight as possible. That's the disadvantage when you do, say, a femto laser, which is a closed chamber. So you don't want an open chamber. So your main incision, so rexis, if done from the side ports or the smallest, this thing always gives you better result. And it is always very, very safe to extend the rexis after putting in the IOL. Like I think he might have to extend it a little bit because there'll be a large cover. Sai, can you just reduce the mag?
Magnification can be reduced.
Is that okay?
Yeah, that's fine. Good.
So I'm using an intuitive machine here. It's not a very hard cataract. Just
So you would generally like to make a trench before you finally chop it?
Yeah. These sort of cataracts, sometimes it's difficult to judge the depth. So my preferred technique is always a stop and chop. Of course, you can also go ahead with a direct chop also.
In these cases, it is also very important that you put the retro illumination on before the case, because sometimes what happens when you forget and you make the case and your retro is on, then it always helps.
Sometimes after cortex aspiration, the nucleus will be very mobile. So in such cases, we go for a direct chop. So because of the cortex is debulked, the nucleus is very mobile, then we go for a direct chop.
So actually, the intuitive machine is a significant upgrade over the earlier compact that they had.
Correct, correct.
I will put it almost at par with the signature that was there. The Signature Pro, I would say, is a little still better as regards search control, but you can have the intuitive light with and without the effects. I think now they
Yeah.
have, yeah.
So
And
that
as
was
was rightly pointed out, at least in my personal hands, I prefer always to do a direct stop. Uh, there are very rare instances where I want to do a stop and shop.
Pranayama.
At this point, one can actually go on to the epinuclear mode.
Yeah.
When you tend to have a
Chamber is got excellent chamber stability also, sir, this machine.
yeah, I know.
so side that was just a textbook like picture
Yeah.
of eating away the entire nucleus, huh?
So one important thing to note is that whenever you're using a signature or even an intuitive, you can actually go ahead with a 20 gauge, 21 gauge, or even a 19. I prefer to use a much wider board, and the lumen inside is not constricted as in some other machine.
Yeah, yeah, yeah.
So if you are actually dealing with a rock hard cataract, you have to actually stop in between. You have to flush the tip, and also which does not have happen in these machines.
So he whisk.
So I don't know whether you agree with me, Sai, or not, because
Yes, sir, definitely. Room lights off.
It's become a little dark side, so
Yeah. I just switched on the retro.
okay.
So which lens are you planning to implant?
I'm planning to implant a synergy, sir.
Okay, great.
അയ്യല്ലേ കിടക്കുന്നത് കോട്ടക്സ് ആകെ
So 23 diopter synergy, sir.
Okay, great. What has been your experience with this synergy so far?
Synergy, I have not implanted too many lenses, sir. I've implanted about 4, 5. So far, they've been doing good.
Okay.
And in that category, I think it is definitely better for near vision compared to the Symphony. Symphony is an excellent lens, but near vision is slightly.
Symphony is not really a comparison. I would say it's better than the other trifocals, even the
Yeah.
because
Correct.
that is giving you a good reading ability at 40. So this gives
Correct.
you a continuous range of vision starting from 33 centimeters.
Lens kuduma.
Would you wish to tell the audience something about the synergy as to how it is different from other?
I think you will be a better person, sir. just beginning to use the synergy. Just implanted a few lenses. Of course, I can say some theory, but I think you will have more experience with this synergy, sir.
Okay, you can say the theory. I will say the practical. So anyway, I think this is, you can see the tint. Can you just show the tint? It's
yeah, the slight yellow
not a yellow lens, but you can see that there is a mild yellow
tint is there.
Yeah. So what it does is that it cuts out it is not a blue light filtering lens, but it cuts out the harmful extreme, the spectrum of the blue UV light that is there.
Okay.
So therefore, what they say is that you can have effects on the circadian rhythm, etc. So that is not there. The second thing is that this is based on the Technis One platform.
Yeah.
So it is the same, and it's the same injector which you are using.
The same injector as Technis One. Actually, all the lenses across the board have the same platform, and I think that Technis One is a very time-tested platform. And
you can use in the unfolder both the screw type or the push type.
I generally use the screw type, sir. I'm so comfortable with the screw type. I hardly use the pusher.
Yeah, because the screw gives you better control.
Yeah.
You can stop at any time. Sometimes the push type comes with a jerk.
Correct. It comes with a jerk. It can go and hit the capsule or the rexis margin.
So this is basically the square edge that you have. The other thing about this particular lens is that they have the proprietary technology, which they have. The asphericity is obviously part of the techness thing, and that's part here also. But the other important thing is that they have got the achromatic or the chrome-align technology. So, Sai, would you want to say something on the chrome-align, or should I say?
Yeah, I think you can say, sir.
Okay, so basically, apart from the spherical abrasions that you get on the IOL, within the eye, sorry, you also get chromatic abrasions within the eye. So that is very, very disturbing, especially in dim light as regards the bad contrast when you have. So if you cut out the chromatic abrasions by the design of the IOL, that will give you excellent vision even in dim light conditions, and that is very, very important, which is there. The third important thing which is there is that it is what is known as a CRV, or a continuous range of vision lens. I think the central 1.1 or 1.2, you start with the first ring, and there are 15 rings which are there. And they are basically a combination of what is known as a trifocal lens with a EDOF lens. So that means that within the three ranges that you have of the 33 centimeters and the intermediate and the distance, you have an lens which is an extended depth of focus. So there is actually not three distinct focuses, but there are three focuses. In addition, there is a continuous range of vision. So they prefer to call it as a CRV lens, or a continuous range of vision lens, rather than just a trifocal lens. Yeah, Dr. Said, what you're doing is an excellent maneuver of removing visco. Just tell us something about from the back.
No, we go under the IOL, and actually with a bimanual, normally I am, most of the cases I use a coaxial for my irrigation aspiration. But when I'm using bimanual in such cases, I reduce the vacuum a bit because sometimes the flow of fluid in a bimanual is not as good as that through the sleeve in a coaxial. So I go a bit slow, but you have to make sure, obviously, that you're removing all the viscoelastic from inside the eye.
Yeah, and it's a very well centered IOL just now. One of the things that you can do is to actually have a marker to see as to the size of the rexes.
Yeah, actually,
manual marker. Yeah, go ahead.
Actually, I also have a Virion technology with us.
Yeah.
So we use that in most of the cases.
So would you be extending the rexes in this, or you think it is okay?
It looks good enough to me, madam.
Yeah, it looks
I'm not planning to extend, because one area it is slightly smaller superiorly, but the rest is quite okay. Now, if I try to extend it and it becomes too large, then positioning becomes an issue. So I'm planning to leave it like that.
So basically, sometimes if you have a very small rexes, you get phimosis, and you can have a problem of a decentration. And the other thing is that dysphotopsia can become disproportionately large because of the interplay between the rexes and the lens.
Yeah.
So
but in this lens, except for a small area superiorly, the rest of the rexes is almost aligned to the last ring of the lens.
Yeah. And one of the tricks to do a rexes at this particular time is maybe not to use a scissor. You could actually use the iris repositor kind of a spatula, which you put below the rexes, lift it up because the lens is there, and then do a small needle.
Small nick with the needle. Yeah. That was the initial technique. Yeah. I'm through, sir. Madam.
I know it was such a effortless thing, Sai, that we before we realized the case was already over. Very well done.
We have also put in some intracameral moxifloxacin, but now as a standard we are doing for all cases.
For all cases.
Thank you, madam.
Do you think it has reduced your incidence of
Definitely. I mean, we have not done a study as of now, sir, but definitely touch wood. I don't have any wood here to touch now. but we have not seen a single case of endophthalmitis after having started the intracameral moxifloxacin.
You can touch your head.
So far.
Okay, so that was.
Can we shift? Yeah, can we shift to the retina side, sir?
Yes.
So
surely.
any comments you want to say? It's important to seal the incision. At times, some people use a dye to see that it is well sealed, because the endophthalmitis happens only in the earlier period when if the wound is not
will
tight enough and you
about
can
Correct, correct, correct.
We'll
Yeah.
talk
we
about
have-
that.
Even if you look at the large
will ask him.
ESCRS study of endophthalmitis, which started propagating cefuroxime,
yes.
the incidence was actually much higher than even in our country. So, but then the initially, the wound construction, there were a lot of issues. But with the smaller wounds that we have now, I think that also has gone a long way in reducing the incidence of endophthalmitis. It's not just the moxifloxacin alone.
Do you have an access to flax?
Yes, sir. We have flags. We regularly do flags.
So
Yeah.
you're not showing flax,
Not today, sir.
Ready, we
right?
will stop here and go.
Yeah.
Okay.
Thank you,
Then
sir.
we'll
So
come
we'll
back
shift to
again.
the retina side while I
Thank
get my next intumescent cataract ready.
Okay,
So
thank
don't
you.
you prefer to use a flax for intumescent cataracts?
I do, sir. I do, sir. Today we are not demonstrating that, but I prefer to do a flax in such cases where the
Mother
rexus
had
is very
asked,
effortless.
Mother had a, my opinion.
You don't have to worry about this nick and extension and things like that.
Mother had,
But I thought that
No.
how many people watching today, I mean, I don't know how many will have access to flax.
No,
Flags.
that's what I'm trying to just ask you, because is
Yeah.
your penetration of femtolaser increasing as regards the percentage of the total cases?
Right from the beginning, it's been remaining about 10%, sir.
That's
Between 8 to 10%.
Okay.
During the pandemic times, it was actually a bit less because
Mm.
people were having some affordability issues, but it has picked up again. So I would say it is roughly about 10%. So if I do about 300 cataracts a month, about 25 to 30 will be flax. It hasn't increased beyond that.
We are seeing a significant surge in Delhi, I would say, as regards the femtolaser procedures, and the numbers have actually gone up. I was talking to a representative of J&J. They have sold the maximum number of LOIs ever in their lifetime
Okay.
in January, in February, and March.
Okay.
Can we shift to the retina?
Yeah, can we shift to the retina side? Yeah.
So Dr. Girdhar is going to demonstrate retinal detachment surgery, and Dr. Mahesh is there to help us to moderate.